Hello and welcome to another intensive care hotline and intensive care at home live stream. Thank you so much for coming on to this show. Also, thank you for those of you who are watching this on replay. Before we go into today's questions, just want to spend 1 minute about myself, what makes me qualified to host live shows about questions answered for families in intensive care. I am a critical care nurse by background. I have been working in intensive care / critical care for over 20 years in 3 different countries. I have been working as a nurse unit manager for over 5 years, and I have been consulting and advocating for families in intensive care at intensivecarehotline.com for over 10 years now. If you want to look up any results from clients, you can look at our testimonial section, or also at some client interviews in our podcast section. I'm also the founder and managing director of Intensive Care at Home. You can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending intensive care nurses and critical care nurses into the home predominantly for long-term ventilated and tracheostomy adults and children. Currently, we are operating all around Australia in all major capital cities, as well as in all rural and regional areas. Now, without further ado, let's go into today's questions. Also, if you want to answer questions here, you can type them into the chat pad, or I can get you live on the stream here. If you click on the link that I'm just posting now here in the chat pad, you can use this link that I just posted here to talk to me live. You can come on camera and talk to me, or you don't have to go on camera and just talk to me while your camera is off. Either way is more than welcome. Please type your questions into the chat pad or join me live on the stream here. In the meantime, I will start with the first question that has come in this week. We get plenty of questions, but it is so much better if you ask them here on the live stream. Now, let's get right into it. First question is from Robert, who says, my dad is in ICU and he is full code, but the ICU team is telling my sister that it's best if she switches to a DNR due to his heart. The doctor is saying that since his heart is bad, doing CPR would only put my dad in more pain and suffering. Okay. Great question, Robert, and thank you for asking that question. So, generally speaking, I would never advise to give consent to a DNR. And there are a number of reasons for that. Before I go into those reasons, you also have to keep in mind that, let's just say your dad, God forbid, has a cardiac arrest and does need CPR, and he is DNR. Well, he won't get it. That means he's going to die. Do you want that? Right? The reality is that if someone needs CPR, there is probably pain and suffering. Does that mean we deny someone's right to life because there's pain and suffering? Right? There's a much bigger question at play here. You should also consider your dad's point of view. Like, what does he want? Does he have an advanced care plan? What's your dad's religious, spiritual, cultural beliefs? Does he want everything done? Also, first off, no one can force you to do DNR for a family member, assuming you are the medical power of attorney, of course. If you're not the medical power of attorney, you have very little, basically no leverage. But your email is telling me, Robert, that you or your sister are the power of attorney, and obviously that you are struggling with signing off a DNR for your dad. Now, here's another thing that I've observed in all these years working in ICU and in all these years consulting, doing consulting for families in intensive care all around the world. The minute you sign a DNR or you give consent to DNR, it's almost like the intensive care team is writing off a patient, meaning, we won't even try hard enough now because this patient is DNR, right? So the minute you give in, the minute you say, no, I'm happy with not doing everything that we can, which includes CPR, you're almost signing off the death warrant for your dad. You're almost giving the intensive care team a free ticket to not do everything that your dad needs to have in order to improve his situation. Here's another insight I think that is important. So, let's just say you're signing off a DNR and God forbid your dad has a cardiac arrest, he won't have CPR, therefore he dies. We have many families reaching out to us that have lost their loved ones in ICU 1 year ago, 2 years ago, 3 years ago, and they're saying, oh, I'm just reading your blog now, I'm finding myself in a similar, I have found myself in a similar situation a while ago, and I thought, well, why would I let my mom, my dad suffer and have them CPR? It's probably best if I just sign a DNR. Then having second thoughts when they realize, well, if I hadn't signed the DNR, maybe my mom or dad would still be around. Right? I argue that what's currently happening in hospitals, there's an element of population control, there's an element of doctors and sometimes nurses trying to play God, and there's an element of them telling you, well, I know what's best for your mom or for your dad. Well, I know it's best for your mom or for your dad to have a DNR. Is it? So now we're saying, in order for someone to live, they have to go through suffering. Let's not worry about suffering. Let's just put on a DNR. Well, human life is suffering, right? That's how we live. No one can say we're happy all day, every day, and there is some suffering involved in that. Well, what is it that people want? Do they want to live? And they do suffer? Yes, of course. That's been the case since the dawn of human time. And now we are neglecting that. We're saying, oh, no more suffering. It's best for people to die. What a whole lot of crap. In my eyes, anyway. So, we need to move away. We need to go back to more of human principles, that life is sacred. And, if someone's going to die, we're all going to die, then so be it. But before that is the case, we must preserve life at all cost. We must preserve life at all cost. If we don't do that, where do we go from here? That's when, in many countries now there's euthanasia laws and, people are allowed to kill themselves and, that's not preserving life. That's a very nihilistic approach to humanity as far as I'm concerned. Right? Look at the euthanasia laws in Canada now, where people can opt for euthanasia if they're bankrupt, if they have a disability, if they are quote unquote suffering. Can't we help those people with a better approach than euthanasia? Is that all we can offer as a society? Euthanasia? Is that no more we can do? I'm sure there is if we all make an effort. Right? But to be that nihilistic and say, oh, your dad should have a DNR because he's suffering. Sure. Well, I can assure you that most patients in ICU do suffer. Well, ask the survivors. Would they rather be dead? I haven't heard that. I would approach it from that angle, Robert. I would approach it from a more positive angle, and I would approach it from, well, what your dad wants. What the ICU team wants doesn't really matter what they want. Their job is to preserve life. And their job is to help your dad. I hope that helps, Robert. Let's go to the next question. And in the meantime, if you have any questions, please type them into the chat pad, or if you want to talk to me directly, use the StreamYard link and I can get you on live with camera or without camera. You don't need to switch on your camera. You can just talk to me. Depends on, how you want to interact with me. Okay. Now, next message is from Anita, who says, it's 4 p.m. My mom is 87. She ended up with a pneumonia. It's a long story, but I'll highlight everything. She's on a ventilator and she can't get off it and needs dialysis. Now she's been stuck in the hospital for 4.5 months. And it's been very crippling being in there for that long, mentally. And for her and for me, she's also on a voucher that helps her pay rent, and they're ready to kick her out because she can't get home. We live together, and she only has till the end of November of this year to get home. Otherwise, she's going to lose the apartment, then I'm going to end up homeless myself. Okay. Well, Anita, there's probably a fairly simple solution for that. And the solution for that is intensive care at home, right? So with intensive care at home, we are sending intensive care nurses and critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomy, right? And that includes patients on dialysis. Now, with intensive care at home, currently, we are operating all around Australia. We are operating in all major capital cities, including regional and remote areas, right? We are currently, most of our clients are NDIS funded. Some of our clients are TAC funded in Victoria, iCare funded in New South Wales, NIISQ in Queensland, as well as DVA funded all around the country. We have also received public hospital funding as well as Department of Health funding and private health funding. So, we can help you with this very, very fast. If you are in the US, I'm not sure where you are. If you are in the US, we can help you as well with private nursing, right? So please reach out to us one way or another. You can reach out to us at intensivecarehotline.com or at intensivecareathome.com. Use one of the emails or just call me on one of the numbers. So we can definitely help you. If you are in Australia, we also have NDIS support coordination, NDIS level 2 and level 3 NDIS support coordination. Right, and that's how we can help you very fast. Now, in terms of cost, the ICU intensive care at home costs half of the cost of an intensive care bed than in ICU. So there's an economic argument that the hospital might even pay for it. I wouldn't worry about the funding. Just reach out to us so we can take the first steps and help you with the funding as well. I hope that helps, Anita, in your situation. Now, let's move along to the next question. If you have any questions while you're watching this live, please type it into the chat pad or join me live on the show here with the link that I just posted here, the StreamYard link. And I talk to you here directly. And you can answer your questions to me directly. And I, don't need to go on camera, but you can. It's up to you. You keep your camera off. Next question is from Rashmi, who says, my husband had a craniotomy surgery, and after a month, he had a cardiac arrest. He was slowly recovering, but again, after 10 days, he got a second cardiac arrest in which he got a hypoxic brain injury. Please guide me what to do next. He is in ICU. Right. I'm so sorry, Rashmi, to hear that. That's very challenging. You haven't shared with me how old your husband is. You haven't shared with me whether your husband has a tracheostomy, for example. However, I do believe that he probably needs a tracheostomy, assuming he can't come off the ventilator, right? And get a tracheostomy for him, and get a tracheostomy, and then see whether he can wean off the ventilator, whether he can recover. And they need to start things like mobilization, start to rehabilitate him. I guess the question is, what do you want? What do you want? What would your husband want if he had a choice, right? Let's get him a tracheostomy. Let's start him with some mobilization. Maybe he will recover to a certain point. We don't know that. One thing is for sure. If you give up, then it's definitely not going to work. Then it's not going to work. But if you do a tracheostomy and if you keep him there and you keep trying, at least you've given him a shot. But giving up here is not an option unless this is what you want for your husband, or unless and you think that this is what your husband would want. So also, what do the MRI scans show? What does the CT scan of the brain show? Have they done EEG? Those are the questions that you need to ask. You also haven't shared with me what's your husband's age? How old is your husband? Because it all depends on that as well. But really, have you spoken to your husband about a situation like that before? What would he want? That's what it really comes down to. Talk to a neurologist as well, right? Find out what the neurologist says, and keep doing your own research. I was on a call with a client earlier today, very similar situation, Rashmi, and if you push or move towards palliative care, then it's too late. Make decisions today that you don't regret in 12 months' time. Will you regret in 12 months' time if you're potentially letting your husband go today? You probably will regret that. You're probably thinking, oh, well, what if I would have kept going? What if I would have kept going? Would he still be around? Would he have improved? If you're moving towards palliative care today, there's no return from that. Keep thinking things through, which is why you've probably reached out, because you are having second thoughts, and that's a good thing. You need to keep having second thoughts. You can't be rushing into things. And like I said, hospitals, from our first question today, you already know that hospitals just want to rush towards end of life. They just want to clear their beds, and maybe down the line, Rashmi, intensive care at home is an option for your husband. Don't rush into things. Take your time, because it's only been about 20 days or so, which is not a long time. I know it must feel like an eternity for you, but it is actually not a long time. 20 days in ICU feels like an eternity for families because they've been, spending time at the bedside and all of that, but it's actually not a long time. It's very important that you have perspective around this. Most families have no perspective around this. Many families call us up and they say, look, my husband's in ICU for 1 day, for 2 days. ICU is very negative. They're saying we should just pull the plug. After 1 or 2 days, give me a break. Give me a break. Their job is to save and preserve life. Okay, let's move on to the next question. This is a question or a comment from Helene, who says on one of my YouTube videos, at WSAMCS, no physicians informed me of a diagnosis of malaise because it was caused by systemic malfeasance, manipulated malpractices, induced personal injuries that was covered up. Some chronic medical conditions that can cause malaise include chronic anemia, chronic fatigue syndrome, fibromyalgia, diabetes, kidney disease, liver disease, false diagnosis and cover-ups, chronic obstructive pulmonary disease or COPD cancer. Some viral infections that can cause malaise include cover-ups to iatrogenic induced by PAP machine personal injuries. Right. I know Helene has been a guest here on my shows here as well, and I know, I'm very grateful for your comments, Helene, here, to keep highlighting your experience with other families, because I know you've had I think a rough time is no exaggeration by any means. I think the hospital really treated you and your mum very unkind, and that's probably putting it mildly. Okay, let's move on to the next question. Next question comes from John, who says, when critically ill patients can't withstand dialysis due to blood pressure getting too low, they can try CRRT, which is 24-hour dialysis done very gently and slowly, thus sparing their heart, meanwhile balancing blood pressure with vasopressors. Yeah, John, that's a very good observation. That is absolutely what should be happening. So let me explain this. Most patients in ICU that go into kidney failure actually end up on CRRT. CRRT stands for continuous renal replacement therapy. It's basically replacing the kidney with a dialysis machine. However, there are differences in how dialysis or renal replacement therapy is done. First one in ICU is with hemofiltration as part of CRRT. Second option is to do dialysis. Now, the more gentle approach is hemofiltration via CRRT, whereas the less gentle approach is dialysis. Let me explain. For a patient that's in chronic kidney failure and needs dialysis multiple times a week, they're going to a dialysis center often, or they do dialysis at home, and they remove 500 mils within just a few hours. That's sort of a lot of fluid removal within a short period of time, and for patients that can tolerate that, that's fine. Now, most patients in ICU are hemodynamically unstable. Their blood pressure is up and down, is often down in ICU for a number of reasons. They might have sepsis, they might have hypovolemia, they might be on medications that decreases their blood pressure. So there's a whole range of reasons why it's more likely for a low blood pressure, while it's more likely for critically ill patients to have a low blood pressure than a high blood pressure. So if patients are having a low blood pressure and they're going on dialysis or CRRT, and you're taking out 300 to 400 mils of blood out of the body, running through a dialysis machine, that decreases the blood pressure even lower, right? Then you can do two things here. A, like John says here, you can use vasopressors or inotropes to increase the blood pressure medically with medicine, or you can maybe give a fluid bolus before dialysis, or you can give red blood cells or platelets or FFPs, depending on what's needed, right, to top up the volume in someone's body to maintain a blood pressure that's compatible with life, right? And also, like I explained, with dialysis, a lot of fluids are taken off within a short period of time, whereas with CRRT or hemofiltration, blood is removed more gentle over a period of time. So let's just say your goal is to remove 500 mils from a patient. With dialysis, you can achieve that within a couple of hours or so. With CRRT, you can achieve that over a 24-hour period, right? Which means you're much more gentle at achieving that goal, which most critically ill patients need. They can't have those massive spikes in fluid removal, where you take 500 mils off within a couple of hours. That could lead, once again, to hemodynamic instability, which is exactly what John is explaining here, right? So I hope that clarifies and explains, how this should be handled. Now, let's move on to the next question. If you have any questions, just type them into the chat pad here, or you can join me live here by clicking on the link that I posted here, the StreamYard link, and then you can talk to me live on the show here and ask your questions here. Let's move on to the next question that's coming this week. Next question is from Elliot, who's made a comment on one of my videos, who says, "Hi Patrik, I'm not a doctor, but if you're still looking for answers, from what little I know about brain injuries, brain damage can be delayed. The brain swells for several days after the injury, which can cause further damage. This might be why patients get worse after the day of their injury and stop responding. But I would ask the medical team for clarification if possible. Best wishes." Yeah, sure. Elliot, that makes sense. That's right. A lot of swelling happens in the first few days, then the swelling goes down, and then often patients are slowly waking up. Whether they wake up to the degree that they are as functional as they were before, we don't know, and that's sometimes not the case. But, the reality is that you need to keep trying. You often don't know if patients recover or not, or to what extent they recover, unless you give them time. And the hospitals often don't want to give them time. Just keep that in mind. Next question. From Nessie. Nessie says, "We don't want nurses to start lacking in care for my dad. His inflammation in his lungs, in brackets pneumonia, is that correlation to his fast heart rate? Why hasn't a cardiologist come and see him? What about physical therapy? What about a social worker for the family? The head doctor comes in to speak with us instead of the student doctors. Why are the nurses being standoffish with us? Do we need to be careful how we speak to nurses, or else they don't care for my father properly? What's the hold up with moving him from ICU to the telemetry unit?" Well, it looks to me like you've got a lot of grievances in the ICU where your dad is currently at, Nessie. So, is the inflammation in his heart pneumonia, is that correlation to his fast heart rate? Now, I don't know that, but my experience in ICU is that if someone has a pneumonia, that means they are having an infection. An infection can cause a high heart rate. But bear in mind, if your dad is ventilated with a breathing tube in the throat, he would be very uncomfortable, even though he might be in an induced coma still. Right? If he's uncomfortable whilst he's in the induced coma, his heart rate will be high. It's a sign of discomfort. Other things that often happen in ICU which could lead to a high heart rate. Your dad has a pneumonia, and it sounds to me like he's on a ventilator, even though I can't be 100% sure. So if he's on a ventilator and he's got pneumonia, they would not want your dad to be fluid overloaded. What that means is, in order to wean someone off the ventilator successfully, you want to keep them, quote unquote, dry. If you fluid overload them, there's more fluids accumulating on the lungs potentially, right? And especially with a weak heart, there could be fluids pushing into the lungs, delaying and making it more difficult for your dad to be weaned off the ventilator. So the high heart rate could be a sign of infection, discomfort, dehydration. Those could be the three major reasons why your dad's heart rate is so fast. Why hasn't a cardiologist come and see him? Well, have you asked for one? What stops you from asking? You don't need my permission, you just ask. If he has a high heart rate and they need to investigate him for that, you should absolutely ask for a cardiologist. What about a physical therapist? Well, 100%. Your dad will need a physical therapist in a situation like that. Right? Because your dad needs to get mobilized, he needs to get moving. That should be the goal for any patient in ICU, irregardless of their condition. Right? So what are you waiting for to ask for a physical therapist? Social worker for the family, absolutely. You haven't got one? Ask for it. Again, you won't need my permission for that, to simply ask. Then you're saying the head doctors come in to speak with us instead of the student doctors. So the student doctors are talking to you instead of the head doctors. Is that what you're suggesting? Well, that's a concern. That's a concern. Again, ask for that to change. But I'll have something else to say there in a minute. Do we need to be careful how we speak to nurses, or else they don't care for my father properly? Well, you should never be guided by fear. Fear should not be your deciding factor whether to ask for something or not. You should ask for it regardless. If you feel like things are not right there, my advice is for you to make a complaint to hospital executive. That is my advice here, Nessie, that you make a complaint to the top. We, generally speaking, have very good outcomes by either writing to hospital executives directly, because that's what we do, or advise clients to write to hospital executive. Hospital executives cannot ignore the complaint of a patient or a family. They can't. Right? So that is your best bet here. Okay? But it also comes down to that what I've been saying over and over again, that the biggest challenge for families in intensive care is they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly what this is all about here. You don't know what you don't know. Right? But at least now, you can take the next steps. And if you get stuck, just reach out to us at intensivecarehotline.com so we can help you with the next steps. Next question, which is again from Helene, who says, as for LTAC, my mum was sent to Wellstar LTAC on the 11th of June and select LTAC due to emergency hospital transfers, personal injuries, iatrogenic malfeasance and assaulted batteries. As for hospice, the Golden Living Rehab case manager manipulated and coerced me to sign a consent to home hospices, a MEDIS, to receive medical equipment such as hospital beds, nurses, air mattresses, physical therapy and home health. Well, Elaine, I am very sorry that this was your experience there, but this is what we are here for. That's why we are saying you can't really, go into a situation like that by yourself without having a professional consultant or advocate by your side. You can't, because that's what happens. Biggest challenge for families in intensive care is that they don't know what they don't know. It's as simple as that. Right? And look what happens, in your situation. I know your mom has passed, but, if you had someone by your side, this, I argue, wouldn't have happened. Okay. Then let's look at the next question from William. Thank you for your videos. Hi, Patrik. My brother is 35. He went into cardiac arrest 6 days ago whilst in the ambulance while on the way to the hospital. It took him 15 minutes and 7 rounds of CPR to revive, but didn't wake up. What should we do next? Well, William, you should be waiting here. 6 days in ICU is not a long time, and 15 minutes of CPR, it really depends on how effective CPR was. It really depends on, does he have potentially irreversible brain damage? I don't know, right? Patients don't wake up if they've been in an induced coma. and they have no brain injury, right? You take them out of an induced coma and they still don't wake up. It still takes them sometimes days, potentially sometimes weeks to wake up. So, you've got to be patient here, William, and you need to see how things are going. Very early days here. Keep that in mind. Very early days. 15 minutes of CPR, it might be fine. It might not be fine. He needs to be seen by a cardiologist. He needs to be seen by a neurologist, to determine the next steps and see whether there's been any brain damage. Have they done a CT scan of the brain, an MRI scan of the brain, right? What are the blood works looking like? Is he on sedation, opiates, and or anti-seizure medications? Because if he is, that's potentially further delaying him waking up, right? So very challenging, but it can be overcome. Let's move on to the next question from Aaron, who says, "Hi Patrik, my father had a sudden cardiac arrest at an airport. Bystanders rushed to perform CPR within 2 or 3 minutes. My mum said the paramedics got there and performed CPR for a little over 20 minutes. Before going to hospital, he coded again in the ambulance. He has been sedated with a breathing tube for 3 days now and had an original CAT scan and said there was no severe damage, but the EEG came back as showing not a lot of activities. Going to MRI today. The doctors don't seem very optimistic about him. Help." Well, Aaron, thank you so much for writing in. Well, the doctors may not be optimistic about it, but you may be, and that is entirely up to you. You can't control what happens to you. What you can control is how you react. As a matter of fact, that's the only thing you can control. So, will you react with a positive outlook? Will you react with a negative outlook? The choice is entirely yours, right? It's as simple as that. You choose how to respond. Similar to the other question, 3 days in ICU is not a long time. Has he had a CT scan of the brain, MRI scan of the brain, EEG? Does he have seizures? Is he still on inotropes or vasopressors? Did he have an angiogram to screen his heart while he had a cardiac arrest? Does he need a tracheostomy as a next step? Those are the important questions here, Aaron. Okay. Do not give up, because if you're giving up, once again, make decisions that you don't regret in 12 months' time. Make decisions today that you don't regret in 12 months' time. Once again, we have so many families reaching out to us after they lost someone in ICU, and they say, "Oh, now we found your website. We had no idea someone could advocate for us. We had no idea that we had a choice. We just believed everything intensive care teams were saying." And then it's too late because their loved one has passed away. And families literally signed off on that. And then they come to us wanting a medical record review because they have second thoughts. Well, what about having a medical record review in real time? What about that? Doing a medical record review whilst your loved one is in ICU, getting a second opinion. What about that? Right? That is the much better option. Now, before we get on to the next question, once again, type your questions into the chat pad. Or if you want to talk to me live here on the show, just use the StreamYard link that I posted there. And you can talk to me live on the show with your questions. You can go on camera, you can stay, you can leave the camera off. It's entirely up to you. Entirely up to you. Now, from Ashley says, "My fiance is in the hospital now. His heart stopped for 10 minutes and was R. but he has blood clots in his heart, lungs, and legs. He didn't follow any commands for 5 days. He seems very different. He opens his eyes, but it seems like he's there, but not there. Can anyone please tell me if he sounds like he suffered any brain damage? The doctors tell me if he did or he didn't. Because he's unable to get an MRI and he's unable to receive the dye for the CT scan because of his blood clots. Okay. He seems very different. Yeah, any patient will be very different after coming out of an induced coma or being in an induced coma. You can't really recognize them to where they were before. So you got to give it some time before you see any change. Right? It's not unusual. You got to give it some time to change, and you might have to wait for what other people perceive might be a long time. You might have to wait for weeks, for months, maybe even for years. I don't know, but you got to give it some time. If he suffered brain damage or not, you will find the answers in an EEG, in a CT scan of the brain, in an MRI scan of the brain. So that's how you will find the answers here. The doctors didn't tell me if he did or didn't have any brain damage. Well, once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly what you are dealing with here, right? So, don't give up. Do not give up. I'm just changing my position here. Do not give up here. If your fiance, it's only been 5 days. Some people wait for 50 days and then they see a change. You've got to be very patient here. Some people report a change after 5 years, right? It really depends on what you want. It really depends on what you want. But do not give up. And even if your loved one is dying, which I don't know, again, how do you want an end-of-life situation to look like? You just want the hospital to tell you that your loved one is going to die, your fiance in this case, and that's it. Even if you think he's dying and you agree that treatment should be stopped, what should that look like? What should that look like? Do you want to have a say in that? I'm sure you do. You can't just have people bulldoze over you with their agendas. When you have a loved one in intensive care, it's a once-in-a-lifetime situation that you can't afford to get wrong. Very simple. You need a second opinion. You need someone to work with you one-on-one. It's imperative. Absolutely imperative. What if your fiance went on to neurology rehab and there will be some improvement? Right? Make decisions today that you don't regret in 12 months' time. Okay, let's move on to the next question from Cindy. And Cindy says, my biggest frustration right now is that my mom is on the ventilator and trach in ICU. Okay, that is a massive frustration. It's a massive frustration for you and for your family, of course. It's also a massive frustration for the person that's in this situation, right? So if your mom is stuck on a ventilator with a trach in ICU, well, I have two solutions for you. One is read my article, How to Wean a Critically Ill Patient Off the Ventilator and the Tracheostomy, step by step. If that can't be achieved because your mom is too sick, too unwell, too weak, whatever the case may be, then my recommendation is to look for intensive care at home, right? Go to intensivecareathome.com and contact us there. With Intensive Care at Home, we are currently sending intensive care nurses and critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, right? And it could be that your mom fits that criteria, right? Because there's no quality of life in ICU, potentially no quality of end of life, depending on where the care of your mom is at, right? And you have no control. You're living, you and your family are quote unquote living in ICU. That's not a life. So what you should be doing is going home with your mom with intensive care at home, replicate the intensive care bed at home, right? And improve your mom's quality of life, but also improve your quality of life, and also from a hospital point of view, the hospital needs the ICU bed. So they want to free up the ICU bed. Well, one way they often free up ICU beds is by removing life support prematurely. You haven't mentioned anything about that, so that's good that you didn't mention that. So, they need the ICU bed. So for them, it makes sense to use a service like intensive care at home. Okay. And whoever's paying for the bed at the moment, an ICU bed costs $5,000 to $6,000 per bed day. Intensive care at home costs approximately 50% of that. So whoever's funding the ICU bed at the moment, wouldn't they be interested in cutting the cost by 50%? Can you see that it's a win-win situation? Your loved one can go home, improve quality of life, quality of end of life at home. You and your family can stop living in ICU. The ICU needs the critical care bed. They want that. And the funding body, who's ever paying for the ICU bed at the moment, wants to reduce cost. It's a win-win-win situation. I don't know about your location, where you are, but currently with intensive care at home, we're operating all around Australia, in all major capital cities, including regional and rural areas. Like I said earlier, we are a TAC approved service provider in Victoria, NDIS approved service provider all around the country, ICANN New South Wales, NIISQ in Queensland, DVA. Some public hospitals have paid for our service, departments of health have paid for our service, private health funds have paid for our service, right? We also offer NDIS level 2 and level 3 support coordination, right? And we have critical care nurses ready to go to make that happen for you. If you are in the US or in the UK, you should still contact us because we can help you with private nursing. Okay, Cindy, I hope that helps you and your family to take the next steps here. Let's get on to the next question from Howie, who says, so Howie's frustration is, why was our grandmother suddenly put on a ventilator after getting admitted to a retirement facility? Wow. So basically what you're suggesting here is that your grandma went into a retirement facility. Next thing you know is that she ended up on a ventilator in ICU. I don't have the answer to that. But then again, this is another indicator that, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care. But B, it also goes to show that, once again, families in intensive care, they need help. They need a second opinion. They need a guiding hand. They need a guiding light, because they don't really know what they signed up for when they have a loved one in intensive care. Clearly, that is the case here. So, Howie, we can look at medical records. We can talk to doctors and nurses directly, find out pretty quickly why was she put on a ventilator, what happened. We can find that out very, very quickly for you. Never walk that path alone when you have a loved one in intensive care. It's too much to take in unless you have the specialist knowledge. after having worked in intensive care for over 20 years, I can walk you through it step by step. Let's get on to the next question, which I need to zoom in. Which I can't. Again, this is a comment from Helene, who says, after mum's return from ventilation and tracheostomy surgery, the surgeon intentionally didn't prescribe pain medication. I had to advocate for her to prescribe pain medicines. Adversely, she then retaliated and prescribed an adverse amount for my mum. Now, Helene, I will say this. I doubt that very few patients after tracheostomy surgery need pain medicines. Now, one of the main reasons you do want to give or do a tracheostomy is to eliminate opiates, which are strong painkillers, and sedatives. So, prescribing pain medications for tracheostomies doesn't make a lot of sense. The simple reason for that is that, again, one of the main goals for a tracheostomy is to not have any pain, right? We have clients at home living with a tracheostomy. They are not on any pain medications whatsoever, right? A breathing tube in the mouth is so much more discomfort for a patient. So, I don't know what happened here. Maybe you can revisit the medical records, but I argue your mom should not have had any pain with a tracheostomy whatsoever. Okay, let's look at the next question. It's also from a family member here who says, I painfully suffered contemporary observations, complex post-traumatic stress disorder with anxiety, a vasovagal syncope episode and hypotension from first-hand knowledge, and shocked to my mum being medically tortured and restrained in medical trafficked by wayward, corrupted healthcare system and Humana. Iatrogenic malfeasance, drug and chemical manipulated induced hypoxia, encephalopathy, permanent brain damages, etc. That is very, very sad that this is what you've encountered in your journey with your mom in ICU. I'm not sure whether you are suing the hospitals for what you and your mom have suffered there. We would love to help you by looking at medical records and see what's exactly happened there. Let's move on to the next question from Livingston, who says, a year ago, the intensive care team did their best to pressurize me. I'm glad I didn't give in. After 2 months with the tracheostomy, my husband was slowly waking up. 12 months after, his vital signs are stabilized, no jerking movement, no tremor. Currently, we undergo intensive physio and speech therapies. Please never give up hope, from Livingston. Well, that's my advice, generally speaking. Never give up hope. Because what is there besides hope? Right? I think I should read this message out again from Livingston because I think it's such a great message. A year ago, the intensive care team did their best to pressurize me. I'm glad I didn't give in. After 2 months, with the tracheostomy, my husband was slowly waking up. 12 months after, his vitals are stabilized, no jerking movements and no tremor. Currently, we are undergoing intensive physio and speech therapy. Please never give up hope. Well, this is another testimonial that, that I say, don't give up. Do not give up. This is what happens if you don't give up. You know what happens if you do give up. Now, I have time to answer another question here from one of you that's joining me live. You can type your question into the chat pad, I've got another 5 minutes left. If you have no questions to ask here, I'll just carry on with the questions that have come in during the week. In the meantime, feel free to type in. I have time for one more question. Now, let's look at the next question or comments from Janet, who says, "Hi Patrick, you are a blessing to all of us going through similar situations. Thank you for taking the time to speak about this. My brother is currently in this situation in ICU, but you have brought high hopes again and to give him time. Thank you." Well, Janet, it's great that you are taking advice and that you're not giving up hope. Once again, what is there besides hope? Never give up on it. Another comment from Steve, who says, "My best mate had a cardiac arrest in 2016. He was 44. He ended up in a vegetative state and was unresponsive for 4 years. He never woke up or spoke to us ever again. He died in 2020, age 48. Rest in peace, Chris." Steve, thank you for sharing that as well. You just don't know what the outcome is going to be like. Would there have been a difference if, your mate's family would have let him go right at the beginning? I don't know. What you do know is that if you are giving up, you're giving up, and there's no return from that. I'm glad he had another 4 years. That's a good outcome. Okay, then last question or last comment here from Melis, who says, "My biggest frustration is neurointensive traumatic brain injury, suspected glioblastoma tumor with holding imaging, surgical removal, partial resection, delaying pathology results." So it sounds to me like treatment is being delayed here. Well, what I would do if I was you, is to make a complaint. If you feel like treatment should be sped up, then you need to make a complaint. But also what I would do is, get a second opinion, reach out to us here, because, you don't know what you don't know. We can look at the medical records and see what the next steps are, or what the next steps should be. Should it be surgery? Should it be second opinion? Should it be making a complaint to hospital executive? There's not enough information in there for me to clearly work out what you need and what you want. Okay, now I do these YouTube lives usually every week, once a week, every Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is 6:30 p.m. Eastern Standard Time on a Saturday in the US, which is 3:30 p.m. Pacific time in the US. It's usually 11:30 p.m. UK. Now, we have a membership for families of critically ill patients in intensive care. If you go to intensivecarehotline.com and you click on the membership link, or if you go to intensivecaresupport.org directly, there you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. I also offer one-on-one consulting and advocacy for families in intensive care over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to doctors and nurses directly, and I ask all the questions you haven't even considered asking but must be asked. I talk to you and your families, of course. You have unlimited access to me if you are subscribing to one of my consulting and advocacy options over the phone. I have worked in intensive care for over 20 years, and I have been consulting and advocating for over 10 years here. Now, I also represent you in family meetings with intensive care teams, so that you have clinical representation there and nobody's walking all over you, so that you get best care treatment and best outcomes, of course. We also offer medical record reviews in real time, so you can get a second opinion in real time. We offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. If you like my videos, give it a thumbs up, subscribe to my YouTube channel, so click the subscribe button, click the notification bell, comment below, share the video with your friends and families. Thank you so much for watching. This is Patrik Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days